It's time for our International Eminence Lecture on events era is ending soon. Why, when and how to integrate CGM or TIR in your practice. Now I would like...
Hi again. I would like now to discuss with you why CGM is important. So now we officially have Libre 2+. Now let's try to understand why this is so important. Those are my disclosures for you. And what I would like to discuss a little bit is glucose in healthy individuals, and then pre-diabetes and early dysglycemia by the WHO, then a little bit about glucose and the brain, then the question of early dysglycemia markers, glucose during pregnancy, during diabetes, and perhaps towards a consensus. So, healthy individuals. This paper from Nature Medicine involved probably altogether more than 8,000 people. Not only they showed what's normal glycemia when you use a CGM and the normal variability, they also showed that females have a lower glucose naturally, which is important and which we do not use in clinical practice. But most importantly, they showed when you use CGM for diagnosis of diabetes, as compared to a single measurement of fasting blood glucose, you get much more people with pre-diabetes, diabetes, and you also get some misdiagnosis. So they suggest that CGM may be a better way to diagnose pre-diabetes and diabetes. And when you look at the data of healthy population and people with pre-diabetes and diabetes, it's a continuum of what you see. And if you choose perhaps time above 140, you see that you can easily distinguish between people that do not have diabetes, that are healthy here, and between people with pre-diabetes and then type 1. So time above 140 can be a good marker of diabetes. So pre-diabetes and early dysglycemia, just a couple studies that show that intervention makes sense. This study, this is people with early dysglycemia, and what they focused on, which is interesting perhaps for India, on muscle strength. So they intervened with CGM, and when these people realized their glycemia, they changed their lifestyle, and believe it or not, the grip in kilograms improved, and the 6-minute walk test improved in this population, just by using CGM. And another study that's also very interesting is a Japanese study. They used only one CGM sensor for lifestyle modification. And look what happened when they did an OGTT after 3 months. There was a significant difference in OGTT just by using CGM. And there is a meta-analysis of using CGM as a behavioral change tool. And as you can see here, it's highly significant. So CGM on its own first is a behavioral modification tool. Why? Because all of a sudden people see their glycemia. If you don't believe me, please wear one single sensor on yourself. And you will learn things that you didn't know. I assure you, because I tried myself and I got very surprised. And I'm not very obese, I'm just old. How's about glucose and the brain? Why is this so important? Well, this study was done in the UK Biobank. And what they showed was, this was people without diabetes, 1/3 of a million people, so an enormous study. They showed that glucose within the normal range is related to cognitive function and to brain volume. And this was highly significant. So even when you adjusted the model for everything, lipidemia, all medications, all your genetic background, because this is a genetic study. So this is really interesting. So glucose is dangerous for the brain, even within the normal range. And when they focused on MRI, again, UK Biobank, please note that between normal glucose and pre-diabetes, already pre-diabetes is significantly different. So glucose in an adult population with type 2 pre-diabetes is very detrimental for the brain. Even if you go to the youngest population, this is a small study because we don't see many young people with type 2, very different to India. But please note that there is already a gray matter damage in young population with type 2 diabetes. Also, mild cognitive impairment is seen in this very interesting study when they showed a very clear effect of glucose over a span of 2 years on the brain, particularly the subcortical gray matter. And if you want a type 2 diabetes using advanced MRI techniques, again, a very clear demonstration of brain damage in relation to the glucose. So obviously, we have something very serious to deal with. If you go again, lifestyle, so multi-domain lifestyle randomized controlled trial, when you focus again on the brain, please note that A1C did not show any relation. But when you look to the functions like process speed, here glucose elevation already was detrimental. So the first message is elevated glucose is damaging the brain, even a little bit elevated glucose. But then, okay, this is the brain. Do we need an early marker? Is it important? Well, look at this study. Again, the UK Biobank, 1/3 of a million people without diabetes, normal, lower versus upper normal. There is a 3-fold increase in the risk of cardiovascular. So now we get serious. 3-fold increased risk in cardiovascular between lower normal glucose and upper normal glucose. No diabetes, just normal glucose. Okay, if we go further, this is a JACC paper for 21. Please note that there is a continuum of damage, cardiovascular damage in type 2 diabetes, and the risk starts with a 3 to 4 times gradient in between A1C of 5 versus A1C of 7. Both very, very within the recommendations. But then please look at this study. This was published last year in JACC, and this is really interesting. This is a nationwide registry, and they had data 30 years before the onset of the diabetes, and then at the onset and 5 years later. Please note, the risk, the cardiovascular risk, was there 30 years before the beginning of diabetes. So we certainly need an early marker. Otherwise, we are too late. First message. Second message, we can prevent cardiovascular if we identify and treat early. So this is a quote. They say 2-fold CVD events, then match comparison starting without diabetes, 3 decades, 30 years after. And this indicates that we need a comprehensive preventive strategy, that we can prevent these CVD events if we act early. Same holds for pregnancy. We know that pregnancy, we have a biological outcome, which is the fetus. And glucose is very detrimental to fetal brain, to fetal heart, as you know all these consequences. And when you use CGM, the outcomes like LGA, large for gestational age, are all considerably lower. Please look at the p-values here when you use CGM and you maintain time in between 63 and 140, which is the recommended target for the pregnancy. Please note that the difference is visible throughout pregnancy in all 3 trimesters. In diabetes, we have grade A evidence, so this is a meta-analysis that shows here, this is for type 2 diabetes, of course, for iCGM, for regular CGM, but please note here the group of non-insulin treated. Exactly the same effect and same significance. So you don't need insulin to make CGM successful. And also the quality of life increased, and this is, of course, a very important message. But let's focus on this study. This is an interesting study published this year, and they compared, after matching, 2,000 people that use only GLP-1 and 1,200 people that use GLP-1 and CGM. So everybody was on a GLP-1. Everybody was on Ozempic. Okay? When they added CGM to this, please note what happened actually. What happened was a very significant drop both in A1C, please look the significance, as well as, of course, time in tight range. So they suggest actually, because it's a 0.5% of decrease in A1C, everybody was already on a GLP-1. But if you add CGM, it changes the way they use it, it changes the behavior, so you get an additional benefit to this. And here, again, a paper from this year, association between time in range and liver dysfunction, so MSLD, a very important metabolic disorder. Please note, time in range significantly related, so was the insulin resistance, but A1C couldn't predict. So A1C is completely useless in prediction of MSLD, whereas time in range predicts this very precisely. Both markers, so even CAP, either CAP or when you use LSM as a prediction, exactly the same. Time in range, please look, the P, highly predictive. Here, even the insulin resistant doesn't work anymore. A1C, completely useless. So we need a better marker, actually, to switch from A1C to time in range to be able to suggest to our people with diabetes and metabolic syndrome to do better. And this is what they suggest in this paper. So finally, CGM for type 2 diabetes, we may have a remission or let's say a range where we are not concerned. And this is time in tight range above 90%. So this is what people can have, and we can say without an increased risk, probably. And then we have pre-diabetes, where time in range is, this is a mistake, between 80 and 90%. Here is correctly written, between 80 and 90%. And this is probably pre-diabetes, or what we suggest, stage 2 type 2 diabetes. And then, of course, everything below is diabetes. And perhaps this is the new way that will be used in the United States and in the European Union. I'm sure in India that will be a better tool to predict risk and to prevent complications of type 2. Do we have a consensus? We were very lucky to already include this time in tight range into our consensus for the clinical trials. So it's already there and people are using it. But then in our Nature review paper that many people that you know co-authored, we already state that all people with type 2 diabetes should have a CGM. It's very clear. It just depends how often they use it here, and that we need more data, and I'm sure India will provide a lot of data because you are well positioned to do excellent research in this field. And please note, this is an IDF consensus, IDF EU consensus. We say monitoring people with obesity, intermediate hyperglycemia, so very early stages, so that we are able to prevent really all complications of type 2 diabetes. Allow me a couple of conclusions for you. So first, glucose is dangerous. Even a little bit elevated glucose is dangerous to the brain and to the cardiovascular, and you probably saw 30 years before your risk of cardiovascular is already double. So this is a very important message. Early detection of dysglycemia is important. Why so important? Because now we have medications. We can induce a complete remission. So if we identify with CGM and if we act with innovative, with medicines like GLP-1 or dual, and they are all available in India, we can really reverse the course. We can prevent diabetes and, of course, prevent the complications. Individuals at risk should be screened for sure, which means obesity and everybody else. And then, very important, A1C in this close to normal range is not useful. So you need a CGM to detect early. Time in tight range is perhaps the new marker. It looks like also the United States Food and Drug Administration is interested in using time in tight range, and we hope this will come very soon. And then, of course, as I said, early intervention, reversal of the course of the disease, and cure of type 2 diabetes. This is what we can do now with early detection and early intervention. Again, warmly invited to Singapore. It's not very far from you here. We'll have very interesting schools here and, of course, a lot of new data, so you're warmly welcome. And, of course, also those that can come to Europe. And with this, thank you again. This is my team that works while I speak. Thank you. If there are questions, I'm happy to discuss with you. If they are not, we need coffee. Yes?
How do we know that 30 years prior, the patient is going to, that means he's a pre-diabetic 30 years prior, is that so?
You know, thank you for this question. The question was, how do we know 30 years prior they're already at risk? The reply is yes. If we didn't have CGM 30 years before, but if we did, actually, these people would have intermittent hyperglycemia, mostly postprandially. This is how it starts. And postprandial hyperglycemia is a well-known risk factor for cardiovascular, and this is what we need to detect. And now, with GLP-1s, you can completely reverse it. With a small dose, these people get normoglycemic again. And with this, the risk is gone.
But how do we know this is the culprit? Because pre-hypertension is also damaging to the brain. How do we know that the cause and effect, that it's the glucose or it is the BP?
Thank you for this question also, because the study was controlled for blood pressure, for lipids. They controlled for all these co-founders to say it. Otherwise, it wouldn't have been possible.
One question, Tadej. Which CGM is the Barbie doll wearing?
Which
Which CGM? Have you gotten your hands on the Barbie doll yet?
Me?
Yeah.
Well, that's a good question. So I obviously had Libre. What can I say? It worked very well.
No, I was asking which CGM is the Barbie doll wearing?
The the Barbie doll. I'm sorry, I didn't understand. I don't know. Can anybody help me? Well, this is a very good, I have no idea, but I will try to find out, because Barbie obviously is important. Any other questions or comments? If not, thank you for being with me.